online and a warm welcome to all the faculty members and delegates present here. I am Dr. Neha Jain, and I welcome you once again on behalf of Emcure Pharmaceuticals to another exciting workshop of No Thrombosis series. I'm glad to share with you all that No Thrombosis has successfully conducted 30 episodes. Today, we bring to you 31st episode of No Thrombosis workshop series. And we are very excited and delighted to have the stalwarts of the country joining us here this moment. I now take the opportunity to welcome and introduce our faculty members for today's program. Just give me a minute. My slides are not moving.
I got stuck in hospital.
Yes, sir. I first welcome our course director, Dr. Shirish Hiramat, sir. Sir is the director of Cath Lab Ruby Hall at Pune, India. Sir was the president of CSI in 2017. He was also the program chair of CSI conference in 2016. He was also the convener of National Interventional Council of India, CSI, from 2004 to 2006. Sir has given many live angioplasty courses to many national and global intervention conferences. He has proctored many intervention cardiologists and has given live courses across the globe. And he has participated in some groundbreaking trials. I now welcome our course moderators. Our first course moderator is Dr. Jabir Abdullah Kuti. Sir is a senior consultant and director of clinical research at Lisi Hospital, Kochi. He is also the in charge of heart failure clinic and the DNB training program at Lisi Hospital. He holds various other key responsible positions like the editorial board member of Indian Heart Journal, the honorary secretary of Society for Heart Failure and Transplantation, and secretary for Cardiovascular Research Society. Sir has participated in some groundbreaking trials, including the ACS Quick Registry, the Kerala Acute Heart Failure Registry, Paradise MI, etc. Sir has special interest in the field of heart failure, ACS, intercardiac imaging and physiology, and anticoagulant and antiplatelet therapy. I now welcome our second course moderator, Dr. A. Srinivas Kumar, sir. Sir is the Director of Cardiology and Clinical Research at Apollo Hospitals and Professor of Medicines at Apollo IMSR, Jubilee Hills, Hyderabad. Sir is also the Chairman of FACTS Foundation and FPS. He is the Founder Director of TCT India South Asia Conference. He was the President of APCSI and also the Chairman of CSI NIC. He holds special interest in TAVI and intracoronary imaging. I now take the opportunity to welcome our guest moderator for today's event. Our guest moderator is Dr. Jaigo Palser. Dr. Jaigo Palser is the director and head of the department and senior interventional cardiologist at Lakshmi Hospital, Palakkad, Kerala. Sir is also the president of Interventional Cardiology Council of Kerala. He is the president-elect of Indian College of Cardiology and associate editor of Indian Heart Journal. He is a principal investigator and national coordinator of Heart Failure Registry. He is also the co-investigator in many trials, for example, the CREATE, Kerala Acute Coronary Syndrome Registry, Kerala Atrial Fibrillation, Pulmonary Artery Hypertension, Primary Angioplasty Registry, and PAH Registry. He is a co-investigator in many ongoing national CSI registries like PRESCO, CSI COVID-HF, and COSTA study. He is actively involved in STEMI and heart failure research in the country and has more than 10 ongoing studies at present. Sir has also performed over 19,000 invasive procedures, including 6,500 coronary angioplasties. I now welcome our key speakers for today's program. Our first speaker is Dr. Vikrant Vijan. Dr. Vikrant is a director and interventional cardiologist at Vijan Cardiac and Critical Care, Nasik. He has a fellowship in interventional cardiology at Amrita Institute, Kochi. He is well adept in performing complex cases, including CTOs, rotablation, bifurcation stenting, etc. And he is trained at various institutes like China, South Korea, Japan, and Italy for complex interventional cases and devices implantation. He'll be presenting an interesting case on status complicators. I now welcome our second key speaker for today's event. Our second speaker is Dr. Sharad Kumar Sahu. Dr. Sahu is a senior consultant interventional cardiologist at some Ultimate Medicare Hospital, Bhubaneswar, Odisha. He's an ex-consultant interventional cardiologist at Apollo Hospital, Jubilee, Hyderabad. He's performed over 15,000 CAGs and around 7,500 coronary angioplasties and 250 balloon mitral valvuloplasties. He's also presented cases and papers in various reputed national and international forums. He'll be presenting an interesting case of LM bifurcation culottes technique. After the case presentation by two of our speakers, we'll also have a wonderful case presentation and discussion by our guest moderator, Dr. P.B. Jaigo Palser. With this welcome and brief introduction of all our faculty members, I would now request our course director, Dr. Hiramad sir, to kindly give his opening remarks.
Thank you, Dr. Nia, and good evening, everybody. I think as we get deeper into these sessions, I'm getting more and more involved, even mentally, not just that I have to be here, but so many times after the sessions are over, I keep thinking to myself if this case could have been done in some different way. So let's start with Dr. Vijan. Dr. Vijan, we would like to hear from you your case.
Good evening, sir. Thanks for your kind introduction. And today, incidentally, also, I would like to say that, we are inaugurating our CSI Nasik chapter, and we have a first inaugural lecture today. And so I would be presenting my case, that is status complicators, someday when, you think nothing should go wrong and everything goes wrong, and a series of events. So I would be just sharing my screen. Which one?
I like the name status complicators.
I hope you enjoy the case too, sir. Just trying to open the case.
I think we have stuck somewhere, sir.
Yeah. So are my slides visible?
Not yet.
Not yet.
I think you need to unshare and then share. We can see your Gmail and something like that. I will do unshare from my side. You can share again.
Yeah, we'll try to. Yeah.
You can share again. I have just unshared. Yes, now it's only full mode. Yes.
Yeah. So I hope my slides are visible now. So a 77-year-old lady who was a hypertensive, non-insulin dependent diabetes mellitus, she was referred to us with NSTEMI. So this was a case which I done about 6 years back, and in one of the government schemes. So there are a few restraints that we have, and clinically she was in CLIP class 1 and anterolateral ischemia on ECG, and her ejection fraction was about 50% with ongoing angina, and tropi was positive. So after doing the angio, we had advised her CABG, and but she said that though she was a vegetarian, but she hated cabbage. And so after taking all the consents, we decided to take her to the cath lab. And the plan was PTCA to culprit circumflex and staged or complete revascularization to LAD. RC was about 50%, so just medical management for that. So we took a EVU 6 French guide, and crossed a cougar wire, and there was, as you can see, a proximal circumflex lesion. And the patient, we put in a 3.018 stent to the circumflex beyond the origin and post dilated with 3 into 6 millimeter balloon. And we had a good result. So now while attempting the LAD, we did sizing with the tip of the cougar wire. And so we decided to put a single long stent. And we did a balloon sizing and dilatation with a 2.5 into 30 millimeter splinter balloon. And did two, 3 dilatations and long balloon dilatation. It could even cross the lesion beyond. So initially, when I tried to cross a long stent, a 3 into 38, we can see it was not getting through. So removed the stent and again pre-dilated with a 2 into 10 millimeter balloon at higher pressures and multiple pre-dilatations again. And you can see that the balloon could go forward easily. So this time, second attempt stuck again, but this time while retrieving the stent decides to stay back. And we can see the balloon coming out and stent is just at the the left main to LAD. So I tried to cross a unopened 1.25 small balloon, which tried to cross the stent, but it got stuck distally. We again tried to cross the balloon, but the whole thing comes out. So second attempt to pass a new balloon, all out. So after this, I crossed a Fielder FC guide wire by the side of the stent, but it was unable to go through the stent. And with the help of micro Andra snare over a microcatheter, hooray! So we could remove the stent. And I'll show the subsequent clip. So I dragged the stent out. I thought probably, I can just go in again and it's a smooth lesion. I can, again pre-dilate it, probably put 2 short stents. But like I said, the title status complicatus, things weren't meant to be so easy. So as we all thought, just the interval. So now I take a check shoot and I see that the guide wire has caused distal LAD perforation and the snare has dissected the ostial circumflex. So double trouble. The blood pressure started dropping and there was tamponade on echo. So there was a perforation at the tip of LAD. I took a 2 into 10 millimeter balloon, kept inflated distally and started pericardiocentesis for the tamponade. There's another wire kept in the circumflex. We can see the short balloon distally. And after some time, we took a microcatheter, passed beyond the balloon, and we injected gel foam. And after that, we put in 2 short stents, as I thought would be the initial plan after the long stent could not cross. And the ostium of the circumflex flap caused by the snare was stented by a 3.5 into 9 millimeter short stent with overlap with the previous circumflex stent. And this was finally the final and the end. So it was a little difficult case. What we thought would take about an hour kept us busy for the next 4 hours. And before even taking her for the cabbage, initially the surgeon said, I'm just leaving. So please, you can go ahead and take her for the plasty. So stable, patient was stable after 6 years. In fact, she came for follow-up in the 5th month, 2021, and stress test done was negative for additional ischemia. So I come to the end of my talk. So we have Senior Dr. Vijan also with us. Yes. We are going to inaugurate the CVTS Society soon.
Hi, Gurudev.
All of you, both of you are smartly dressed, very smartly dressed.
Good evening, sir.
Big occasion for you all, and all our good wishes from this big community for a very prosperous next year. So about the case, the perforation was caused by the wire tip?
Apparently, that's what it looked like, because when we tried to cross the wire by the side of the stent, it had gone distally. And we could try to get the whole thing out. But practically, that was the only reason that could have been caused, because we took a check shoot prior to even crossing the wire, and there was nothing distally.
Yeah, I think it was fairly clear when the tip of the wire was actually when you tried to pull it out. I think maybe in that difficult times, it would have just gone distally, and then I think it was very clear in one of the pictures.
Yes,
so
it was moving up and down multiple times. So that's what we also thought could have caused.
But I think sometimes when you pull it out, the stent like that, we're lucky that the left main ostium also did not get really chewed up. No, otherwise, with a pericardial effusion and the left main at the same time, so it would have been even more challenging.
True.
This was 6 years back. Vinod, you remember this case, or?
Yes. In fact, we told we'll do a free angio. She did a treadmill. Imagine she's walked beyond 9 minutes, Bruce protocol. And she said, how's the test? I said, normal. Then, why do you want an angio? I said, for a record. She said, no. Politely, she refused. She comes. She came a couple of months back. So we named it status complicatus. We have epilepticus, asthmaticus, and we coined our own.
Why do you think the stent had difficulty in tracking initially? The long stent?
Just because it's long.
Yeah, it was a 38 millimeter stent. It was actually not able to go beyond the mid LED lesion. So probably some calcium or fibrofatty plaque. This was the second time we tried to cross after multiple dilatations. Probably it was just getting stuck because of some calcium or something.
Calcific spur. The balloon would go up and down. We were very happy, and yeah.
The balloon dilatations were done with a non-compliant balloon, compliant balloon, or something more than a non-compliant balloon?
So, sir, we initially pre-dilated with a 2 into 10 millimeters balloon and a 3 NC balloon thereafter, before trying to cross the stent again.
That's quite a heavy dilatation, actually.
True.
We didn't use a cutting balloon. It didn't occur to us that time. The balloon went in so easily, so we thought.
Yeah, I think the way the pre-dilatation balloon moved in, one would never anticipate such a problem in tracking that stent.
True.
If you were to do the same case again, Dr. Vijan, how would you do it? What would be the different steps that you would take before you take the stents?
I would have taken a cutting balloon this time. If I feel that, of course, now if we have an IVUS, probably we would have done. But many times, there are cost constraints. It's very easy to say that I would use this, that we have many facilities. And then
let's talk of science.
So poor man's cutting balloon, many times we pass a wire, and over the wire, we use the wire as a cutting balloon.
So maybe we could pass a buddy wire parallel and again dilate with a 310 or 312 balloon, and then try to recross the stent. If it doesn't go, then think of crossing 2 short stents.
2 shots.
So that would be the next.
I think one of the easiest things to do is to have a... Sorry. Go ahead, please.
No, that's what he did again. Because long length was there and lesion was tightly underprepared, and there was a bend there also. All this, I think, contributed together to the problem. Whenever the short balloons are going and the long stent is not going, that means there could be a bend at that point where the lesion is slightly underdone. And the long lengths create trouble. And I don't know which stent it was, but most of the Indian stents are very trackable, good. But once you go into the lesion, when you're coming back, the stents tend to tame back because the crimping technology has to slightly improve there. And then once you're coming back, you should be extremely careful in pulling the stent back. And sometimes when you're taking guideliner also nowadays, the guideliner edge could get stuck to the stent edge and the balloons come back and the stent remains with you, even with the usage of guideliner. As you said yourself, two wires and stirrup technique, I call it. Basically, you hold with 2 wires like stirrups, and then stents tend to track easily. And if that is failing, the next step would be guideliner to take it. That also fails, then probably, as you said, probably previously when stents were more expensive, we used to try all other means to save the stent. Now, actually, you can change the stent and take 2 short stents rather than doing all that, because those are now telescope or that thing has become more expensive than the stent. So probably you can take 2 short stents and do it. But generally, I keep telling to residents and others, God won't be so cruel to give one complication after the other. But here you faced it and called it as complicators. But finally, with the attentive mind, and you could save the patient. That is achievement. Normally, when you occluded the vessel distally, you're worried to put 2 stents proximally. But you did it and nothing happened to the patient. That's a good thing. But by and large, I think successive complications won't happen. At least I have not seen so many happening. Stents get discharged. Again, the perforation happens with the same patient. Again, LC exhaustion gets into trouble, all that. But anyway, that's why you titled it as complicated as continuous, I think. That's how I think it is. Okay. But generally, successive complications, one single patient, little unusual.
Dr. Srinivas, this DCT South Asia is shining at your background.
No, sir, I got stuck in the hospital with the long case. I didn't want to miss this, so I'm stuck in the hospital till now. I didn't go home. Normally, I go home and then do the meeting. So now this is actually a glass where the shade is there in daytime. So I'm just stuck in the hospital. That's why you're seeing it. Normally, you won't see it. Thank you, sir. But good case anyway. Good learning. We have Vijan sir. We met sometime back in some conference. I think. Nice to see you. You both look like brothers, but that also I can take the liberty that also suggests that younger Vijan should be more active. Sorry to say this, but disease is so rampant here nowadays. Young cardiologists and 50-year plus cardiologists lose a lot of weight now because suddenly they see so many patients, they become thin. What happens means now they're seeing they're becoming very active and then doing a lot of activity, exercise, things like that. But sir is maintaining, he's looking like your brother, which is very great. And sorry, don't think otherwise.
No, absolutely not.
Great. Maintenance of health is very important. In districts nowadays, you just are busy with patients, continuous sitting. We hardly get time to take care of ourselves. Exactly. That's also very important. As a brother, I'm just telling, don't think otherwise. Thank you.
And we three have done, you have done the QFR course, right?
Yeah, QFR. We interacted at that time.
And
QFR, sir also wanted to
participate. Trained in Leiden.
I was the first person, probably from India, who went to Leiden and did the first QFR training.
Yeah, that's great. Actually, I'm very fascinated by the technology, sir, because it helps at least to avoid some unnecessary stenting. You do the job.
Yeah.
Okay, go ahead. Sorry.
Bye.
Doctor,
many times,
do you have any comments?
Many times, Dr. Hiramat sir becomes philosophical. Today, I told something philosophical out of science. Please don't mind.
No,
Thank you.
We are all one family.
Yeah. Please go ahead, sir.
Yeah, Dr. Onkar, we go to the next presentation.
Yes, Dr. Sharad sir.
Yes. Good case. Thank you, Dr. Vijan.
Thank you. Thank you, sir.
Bye. Thank you.
I hope you're staying with us for a little while till your
we are. Yes, sir.
I got my own lecture in the same laptop. So once the crowd comes, we switch over. Great.
I was telling Hiramat sir, I don't know whether you joined by then, Dr. Sahu was with us, and in the peripheral hospital in Karimnagar also used to do all these complex cases, and he saved a lot of lives. He has a big fan following in that place. But he has to go back to Orissa now. We went back to Orissa.
Sir, thank you, sir. Am I visible, sir?
Yeah, perfect. You can make it full screen.
Yes, sir. Am I audible also?
Yes. Yeah.
Sir, respected course directors, Hiramat sir, respected moderators, sir, Srinivas sir, and Jaigo Palser. Good evening, everybody. Today, I'll present one complex malevolent bifurcation angioplasty along with RCO angioplasty. Patient is a 8 years male patient who has on and off chest pain of 1 month duration. His ECG is normal. Echocardiography is also normal. Normal LV function. Then this is the angiogram. His angiogram shows left main is short. The mid disease starts from probably from posterior left main, mid left main. Critical block in distal left main. LAD osteum is also very tight, around 80 to 90% stenosis. Left main distal is also 90% stenosis. Mid LAD is also 50 to proximal and mid LAD is also 50 to 60% stenosis. Then this is a small diagonal one. This diagonal 2 is also a large branch, just as parallel LED. And distal LED is also very tight. Then coming to LCX osteum is also very tight, around 70-80% stenosis. Proximal LCX also mild disease. OM1 is mild disease. OM2 large branch, it is also critical stenosed. Then the bifurcation angle, left main bifurcation angle is around 80 to 90 degree. Then RCA is very large dominant. Proximal mild disease. Mid segment is also 70% stenosis and it is giving collaterals to LAD. Then with this we plan for revascularization. We calculate the syntax score, which is 33, which favors CABG. Syntax 1, CABG is favor, here it favors CABG. You calculate syntax 2, the PCI mortality rate is at 4 years 13.5%, CABG is 21%. So we had a hard team discussion with surgeon, patient, relatives. So we go ahead for PCI. So if this is a complex bifurcation, according to definitions criteria, it is a complex bifurcation. We have to plan two-stage strategy from beginning. So here the strategy is preferable, both L6 and LAD diameter is equal. And also the angle is around 80 to 90 degrees. So both T stenting, cooler stenting, and cross stenting all are also comfortable here. So I plan here a cooler technique. So it is just little modification of cooler technique, like decay mini clot. So we know cooler technique is very easier to do than decay cross. And we have to wear both the branches and pre-dilate if required and take imaging study. If required, we'll do modification of the plaque. Then we have to put a stent in the most angulated branch, side branch. Then after that, we have to optimize the branch, the stent and proximal part of the main vessel. Then we will rewire it. And after rewiring, we'll open the struts of the side branch. Then we'll put second stent with some stent proximal to the side branch stent. Then after that, again rewire the side branch and do a kissing balloon dilatation and a report. I have done few modification here. The cooler technique, if you compare with the cross technique, decay cross technique, it is little inferior in comparison in base rate. So we can do some modification like mini cooler. We will put minimal protrusion of the side branch stent into main branch. And if you can do another kiss, then it will be decay mini cooler. It may give good result. So like that I have planned. I took a 7F Jurkin's catheter, guiding catheter, where both the LAD and LCX. It was a little difficult to wear the LAD. Few minutes I wear it. Then I pre-dilated the lesion, means distal left main, posterior LAD, mid LAD, and distal LAD, also LCX. I pre-dilated it to prepare the bed for imaging. Then I do a IVO study. This is the angiogram after pre-dilatation. Then I do eye imaging study. I do IVO pullback from LAD to left main. So it shows the distal LAD is around 2.5 meter vessels, and this mid LAD is around 3, and there is calcification is there around 270 degree, 180 to percent calcification. And proximal LG 3.5 millimeter vessel filled with flex. Distal latment is very tight and it is also 4 millimeter. Proximal latment is 4 millimeter. And disease extend up to the ostium of the latment. I am showing that. Disease extend up to ostial latment. So I have to plan angioplasty from the ostial latment to distal LAD. And the length I measured is around 48 millimeter. Then I took the pullback from the LCX. The LCX distal is around 3 millimeter. It is filled with fibrofatty flex. Only I dilated with the NC balloons. Then the ostial LCX is also tight. Flex burden is more than around 60%. So I planned a two-stent strategy. Angulation is around say 80 degree. So I planned a cooler technique here. So because there is some calcification, I again modified the flex by dilating LED LCX with a 2.5 meter balloon. Mid LED, I did a cutting balloon dilatation with a 2.75 Wolverine balloon. Then this is the bed preparation, and after that, this is the angiogram after bed preparation. Then I first tried to stent the mid LED. So the diagonal D1 is very large one. I protected it with a wire and took a 2.75 into 28 millimeter stent into diagonal in mid LED. Then I deployed it and did good optimization with 2.75 and 3 millimeter balloon. Then after that, I took a 3 into 33 millimeter stent with minimal protrusion into latment, so that their metal burden will be less. Then I deployed the stent and did optimization with 3 millimeter balloon and the latment and ostial LCX part with 3.5 millimeter balloon. Then I rewired the LED through the stent slots of LCX stent. Then I opened the stent slots and did fast kiss with 3 millimeter balloon in LED and L6. Then after that, I took a 3 into 28 millimeter stent from ostial latment to mid LED. And after that, I optimized the stent and latment with 4 millimeter balloon. Then I rewired again L6 through the stent slots of LED and opened the stent slots. And then I did the second kiss with first high pressure, sequential high pressure in the LED and LCX, that is 18 millimeter, 20 millimeter. Then medium pressure dilatation at 10 to 20 millimeter simultaneous dilatation. Then after that, I did pot of latment with 4 into 8 millimeter LC balloon. Then I did the IVA study from LED and LCX. I found good stent expansion and oppositions, no edge dissection, no geographical miss. In latment, I get the area of around 9.5 millimeter square, confluence 11, OLED around 10, mid LED around 5 millimeter. Then LCX also similarly, I get good expansion, ostial means proximal LCX around 7. No means edge dissection or geographical miss, well opposed and expanded stent. Then this is the final angiogram. Then I found some because RCL lesion is around 70%. I confirmed it by doing physiology. The FFR was 0.7. Also, I was the area minimum lesion was 3.4. Lesion length was around 23. So I took the vessel diameter is 4. So I took a 4 into 24 millimeter stent, deployed it and post-dilated it and got this final result. I was also so good stent optimization. So this is the final result. So to conclude, we know that all trials show that two-stent strategy has not good outcome in comparison to provisional single-stent strategy. But definition study shows that according to definition criteria, if the complex bifurcation, two-stent technique yield numerically lower 3-year cardiac death rate. And with stent strategy, if you compare cross stent, classical cross with Coulott technique, Coulott has cumulative mesh rate lower than cross technique. Then when stent restenosis is also lower in Coulott technique than classic cross technique. This means decay cross 3 proved that decay cross is better than Coulott in left main bifurcation angioplasty. Then because there is stent means metal burden is in proximal vessel is higher in Coulott technique. To avoid that side, the result is not good. And ostium of the means side branch is not well expanded in the Coulott technique in comparison to decay mini Coulott. So we can avoid these steps, making a mini Coulott means minimal metal burden in the main branch, and doing a means double kiss to optimize the ostium of the side branch. We can have good results. So this is the double kiss mini Coulott compared to mini Coulott. So compared with mini Coulott stenting, decay mini Coulott stenting was associated with shorter metal kernel length, shorter maximum distance of maloposters, and smaller side branch orifice area stenosis. So it may have good result in comparison to mini Coulott. So decay mini Coulott, and if you compare to decay cross technique, it is feasible. Decay mini Coulott is feasible. It may have good result, superior or not inferior result in compared to decay mini Coulott, decay mini cross, but there is no randomized study. So thank you all for patience listening. If any question, I will be happy. Thank you, sirs. Am I audible?
Yes, very much.
Am I audible?
Yes, yes.
Yes, so Dr. Hiramat, so,
Sir.
yeah, you did a good job. Final result was doing quite well. We'll request our guest moderator to pass comments first. Yes, first.
Yeah, I think Dr. Sahu, very well done. In fact, I'm a great fan of Coulott. In fact, I just wanted to share one similar case like what you have done. Of course, when you go through the literature today, many people look down on Coulott. They say the decay crush has superior results and so on. But I think I would like to share something which has come from the EBZ main also, whatever they have also seen. But I think excellent results. You did a fantastic job. I think this is quite attractive, the mini Coulott, where, some of the disadvantages of a decay crush is that you can, sometimes there is an area where when you crush the stent, there is an area which may remain uncovered, and then there's a problem there, which may not happen with the Coulott. But time and again, the only problem that I tend to see when you have a Coulott, the side branch, as you said, may not be, at least sometimes you feel that it's not fully open, despite all the final kissing balloon and all that. But you did a marvelous job. In fact, taking the entire, it's a total revascularization what you've done for the patient. So, and of course, imaging has really helped you here. And I think there's no doubt in anyone's mind today when you do this complex cases, if it's possible, definitely imaging is a way to go about. And I think you did very clearly demonstrate also. And again, the challenge was you also had an ostial left main. Is exactly one of the similar cases which I also show. So I think that is that sometimes is a very tricky issue, particularly in an unstable patient. But here it is a fairly stable patient, so I think it is well done. Excellent.
Thank you, sir. Thank you.
Dr. Jaigo, even if there was no left main ostial lesion, you would have brought the stent back to the left main ostium, isn't it?
Yes. In fact, sometimes there is an area which is left uncovered. In fact, even on IVAS, there is a bit of a calcium at the ostium, right? So, but then when you have an ostial lesion, which is about 70%, that's indeed a challenge.
I would probably feel that if we get the ostium covered, I think our post-dilatation strategies are very strong and very gratifying. So I would never sort of leave a couple of millimeters at the ostium unstented. Get the ostium covered, make the stent float in the aorta, and this will allow you to go very high on a post-stent NC balloon dilatation. So I would probably feel, I generally take an LAO 30 with cranial 30 angle, and that shows your relation between the ostium and the stent back end. And that's the place I choose to deploy not deploy, at least position the stent. You could deploy it in whichever location you want.
I perfectly agree with you. I think when you do the ostial stenting, that's the way to do it. And also, not only that, it also gives you a length in the left main where you can do a perfect pot. So that's also very important. Otherwise, you have the challenge sometimes is a very short left main. So the shortest balloon that we have is about 6, which may not be always available in some of the shelves. So I think it's important that you really blow up to high pressures, at least in the main vessel, and then get the desired results. Perfectly agree with you, sir.
I think you're also showing similar cases you said, sir. You can finish your presentation, then we can have.
Yeah, I was informed about the presentation yesterday. So I have a little mix of a few complex scenarios which I've done, and I'll share with you. If it's okay with you, I can go ahead with my presentation.
Yeah, please.
Yeah, please go ahead.
So while you're just presenting one point, we had a meeting yesterday with 2 weeks back, Mount Sinai people. So my friend Samin Sharma is known to all of us. We asked him, what is your preferred mode for left main bifurcation? He feels that mini crush is his preferred choice, which is even better than DK crush. I mean, I had noted that point because he's a high volume, and I just thought I might share.
Any particular reason that he mentioned for this?
No, he feels the results, long term, everything. He is very comfortable, and he feels this gives the best results.
I think if I'm in a hurry, or apart from left main, I have a lot of work to do in that case, I take mini culottes. Otherwise, I think a regular culotte is safer and much better in long term. Anyway, he's a huge operator, so we will go by whatever he says. So we are ready for Jaigo Palser.
I hope my slides are visible.
Yes.
Good evening, Dr. Hirmat Xiao, Chairperson, and Dr. Srinivas, and all my other panelists also for the evening. So I was actually informed to make some presentation on challenging scenarios. So I just have a few diverse sort of a presentation, which I'll try to cover in about 15-20 minutes. So the first thing is, we just heard from our friend about the culotte technique. And of course, the big news is always people tend to compare this with the DK crush. And the 3-year evidence definitely shows that there is a higher restenosis and maze at 3 years. So, I mean, the way to go about, many people believe that it's the DK crush is preferable. But I think it's up to the operator. And what you need to understand when you compare the culotte versus the DK crush is that the DK crush can never be done as a professional. Of course, all these things are two-stent strategy. There's no doubt about it. And the key thing is that not many people do a lot of bifurcations annually. They do a limited number. And it's a very complex technique which needs to be really, really mastered well. Otherwise, there is always a potential for mistakes. But no doubt, it's an efficient technique, more so the distal left main, the kind of case that was shown, Medina 111. But the optimal performance of the culotte technique is equally good. And I think the more important message is you need to have at least 3 good pot to minimize the risk of wire passage between the stents and optimize the passage into the side branch. So this is, to start with, I have a scenario. This is a 76-year-old gentleman who I've been seeing for the last 25 years, diabetic, on all hypoglycemic agents and insulin. He actually came to me in 97 with a complete heart block and had a dual chamber pacemaker, and then had a generator change. Subsequently, he was admitted with a history of burning, chest pain, typical angina, band breathlessness with features of heart failure. And the ECG showed a pacing rhythm, evolved anterior wall MI. He had a regional wall motion abnormality of the LAD territory with an EF of 35%. And in heart failure, he was medically stabilized and then taken for an angiogram. And that is what his angiogram showed. Essentially, he had the shot with the tiger actually did not reveal the ostial lesion, but then there was a tight distal left main, ostial LAD, ostial circumflex, and also there was a mid LAD which was also very tight. So he was offered the option of surgery, but then in the ward, next day he became again unstable, and at that point of time, he was immediately taken to the cath lab, and this is sort of a an emergency procedure which was done on him. So that was the EKG changes, a pacing rhythm with a ST depression of the lateral leads. So he was, we upfront, we know that it's a two-stint strategy, 7 French femoral guide, distal LMCA 90%, ostial circumflex was 99, ostial LAD was also 95%. This closing of the mid LAD was another 90%. The ostial LAD, when we put in the guide, we found that this is about 70%. So the question was what to go. And then, as I had mentioned, it's always so after the pre-dilatation, I'm not showing you the entire thing for want of time. After this thing, the first stent was put into the both the LAD ostium and the circumflex was dilated, but both were very tight. And then the first stent was deployed, post-dilated, and then subsequently a pot was done to the first the stent, and then subsequently it was all the techniques have been mentioned earlier, recrossed with serial balloon dilatations optimized, and then the balloons were taken, and then the middle LAD was first stented, the dilated and stented and post-dilated, and afterwards, as I had mentioned, in an LA cranial, the ostium was involved, so this was perfectly looked into, and then there was the overlapping stent. We put in a resolute onyx distally, and then overlap this with again this thing right from the ostium, and then again this was taken, a 4 millimeter balloon was taken, optimized, and then recrossed, just like this thing was just mentioned earlier, and then the circumflex was recrossed, and then again a dilatation of this thing was done, and final, of course, ended up with a final kissing balloon, and then once again a part of this thing, and of course much before that the ostium was also flared well, and that was the result at the end of the procedure. So he had a culotte stenting of the left main circumflex and into the LAD, and of course there was another stent in the LAD. So he did very well, but then the problem is, which I need to also talk to, because this is an elderly gentleman with diabetes for such a long time with a borderline renal function. He was taken, and the next day everything was fairly all right. He was hemodynamically stable. He went into an acute kidney injury. Fortunately, came out with a single dialysis and is doing extremely well at 7 months of follow-up. Of course, did not permit the use of imaging. He was an unstable patient at that point of time, and then of course this thing is also to get an imaging as and when required. So the thing that I wanted to discuss is many people look down on the culotte technique, but then one must understand that DK crush was actually developed by a group from the Asian side, and then the pot is not routinely done. Whereas if you look at the European practice, the pot is the way to go about. Whether there's a proximal stenting also, they go ahead with the pot. And what one must understand, there's been a beautiful comparison where you find that the stent thrombus is actually very less in the European community there. Most of these patients in the DK crush, the follow-up angio was done about 13 months. And if you look at the technique also, it's really surprising to learn that 53% of the bifurcation techniques in the European area is a culotte. And so, whereas the crush is the major one on the other side. And what one must understand, people say that you can never do a bifurcation without imaging. Well, I think today, if you have the option, one must really go into it, like what Dr. Sahu has shown us. Amazing to see the results. But then 60% of the cases, in fact, I was talking to Dr. Bernie Mayer also, this is a very costly thing for them. And majority of this thing is even done without imaging. So I think the message that I want to convey here is that when you use 2 stents, either DK, there is no penalty even if you do a culotte, if the results are very optimal. And of course, all this imaging will definitely be useful, but it's not a must. And more attention should be paid to optimizing the chosen technique than to choosing. And I think what one is familiar with and what one has been doing if you're keeping on doing something which very frequently, I think that should be practiced. So finally, it is to keep it simple, swift, and safe. And that's a way to get the perfect result of the left main bifurcation. So from this, I think I would switch over to another challenging scenario, which was a recent patient, 67-year-old diabetic gentleman, again, hypertensive. He was a fairly stable patient on effort angina, class 3 effort angina, fairly stable, echo was normal, had a positive stress test, and his angiogram revealed critical long segment mid-RCS stenosis. So that was the angiogram shot, very tight, and you could see the calcium in both views. The left was nothing remarkable. The circumflex was okay. LAD had only a minor disease. So the idea was to go for an elective angioplasty to the right coronary artery. And of course, we were mentally prepared to take this patient straight away with a rota. Now, I just wanted to show you the first picture because this is the kind of calcium that was seen even before it was engaged. And the right was engaged with the Judkin, and then of course, since we planned a rota, we also had a temporary pacemaker there. And the problem was, the wiring was okay. In fact, one of the workhorse wires that I use these days is the Renato. I mean, I started with all the Galio wires, the Cougar, and so on. But then most of the wires, these wires, the wiring was a little tricky, but then easily went in. There was always an RV branch where it was going in, but it was possible. But the problem was the balloon would not track. I had 1 millimeter into 5 Artemis balloon in my shelf. That did not track. But then I thought maybe try a different brand. 1.2 urea did not cross. And then, so the question was what to do at this point of time. So the microcatheter wouldn't go. So what to do. So at that point of time, there are different strategies which are thought about. You can either inflate, do a granuloroplasty, enhance your guide support and things and so on and so forth. But what I did here was I took a Tazuno balloon, 1.2 again, and a 6 balloon, and then opened up wherever it went. It opened up. I thought I'll do a granuloroplasty and try to open it up. But then after that, with a little bit of an effort, I knew that it had made a little info. You can clearly see the king there, the calcium which is holding it there. So I was just able to negotiate that area. Initially, I thought maybe even before that, if the microcatheter would reach that, I could negotiate the rota wire. So the microcatheter would just reach beyond that, and then subsequently I took the rota wire and maneuvered the rota wire into position. So that is what was done. Then subsequently, I think I did not have any problem in the sense that there was a lot of calcium proximally also. So the burring was done 160,000 RPM, and then there was little difficulty in the mid portion. I thought whether I had little oversized a burr, but then I didn't want to have a chance there. So this was a 1.5 burr, and then it went on, and then it just suddenly jumped, and then of course it went in after that, and then there was no problem. After a polishing run, I had a fairly good result. That was the angiogram immediately after the rota, which showed that the vessel that opened up, and that encouraged me. So then subsequently all the procedures, where different size of the balloons were taken, an NC balloon was taken, and then they opened up, and I thought I had got a fairly decent opening, but then there was an area where it was really catching, and then but I went on with an NC balloon there at high pressures, and then that also sort of gave way. And then I was fairly certain that I could take the stent there. I thought I had the rota was done, so the NC had opened up. So I thought I could take the stent in there and then get the stent easily. But then that was the lesion after this. Taking a 38 millimeter 2.75 stent was no problem at all. It really tracked beautifully, and I could open it up except that there was a small area of waste in the middle. And I thought, well, the stent is taken up, I would be able to open it, dilate it. But then the problem was, when I took a new NC balloon, it would not go beyond, and the guide would just come back. So I realized that, this is probably a mistake. I should have probably optimized it a little earlier, better. You could see the bend really very clearly at the end of at the last shot there. So at that point of time, I had to take the help of a guideliner support. So with the guideliner, I was able to shove in the balloon there, then take it there, and then open it up. And but then I thought they were fairly well opened up, but there was still an area of this thing there. But at that point of time, I thought anyway, maybe I would need an open balloon or something. So the second stent, since I had a guideline in place, the second stent was overlapped, and then it went in easily. And then finally, I got an OPN balloon also at the site with the help of a guideliner, and then opened it up very well, and then at the end of it had a really good result. So I think the message here is that when you have a complex calcific lesion, even if you're mentally prepared of doing everything, I think the cath lab should be equipped with all the hardwares that you have. The guides, guidezilla, everything should often helpful. Proper wires and microcatheters are important. The smallest of balloons to the high pressure OPN should be there in yourself too, and that is what really helped. But then I think probably one thing which probably would have helped is an additional IVL, what is known as a rotoplasty, rototripsy. It's not just rotablation. Sometimes an IVL can be handful. So this is what you sometimes encounter in calcific lesions. The only thing of word of caution is that when you do these cases, in fact, I have last 2 occasions, I've had patients having really renal dysfunction. So I think the important message of an ultra low contrast angiogram and PCI should also be kept in mind. Use small catheters without side holes, 2 ml injections, removal of the contrast from the guide wire, avoidance of the puffing. And if you have a road mapping and if you have really studied the angio very well, and of course you could use IVUS and make sure that particularly the new transducer gives you fantastic images. And so the philosophy of the zero contrast angiography should really be studied and could be optimized, particularly in renal failure patients. And something called a live IS guided PCI is also really coming up. Of course, you have heard about the saline OCT, but I think these are important things to be learned. So from this, I switch gears to a very passionate area of which I always keep talking about is the primary angioplasty scenario, where you have a huge thrombus burden. I'm sure any interventional cardiologist, whatever the level of experience that you have, when you are confronted with the thrombus, you have all these phenomena like the no reflow, stent thrombosis, distal embolization. And again, all these are really, really uncertain patients with uncertain outcomes. I just wanted to show you some of our own philosophy, which we thought, and now we have got it published. This is a 47-year-old. This is a guy in the recent COVID times, anterior wall MI, central chest pain, little tachycardic and had LV dysfunction, extensive anterior wall MI. His antigen was negative. We have never actually, never ever denied the opportunity of primary PC in the last 1.5 years. We have always taken them up. He was taken up for a PAMI, and that was the EKG at the time of admission. He was in. You could see the chest X-ray with congested lungs, and the right was fairly normal, and the left is what was scary. You had a huge thrombus in the left main, and the LED was not really seen. You have a circumflex and a big ramus there, and that is what was. So many people in this scenario try to do a lot of things, trying to take away the thrombus extraction catheters and so on. Our philosophy has always been very different. So we have believed in this philosophy of tenecteplase. Actually, our experience started way back in the late 90s with urokinase intra for the peripheral arterial disease, and this is what we have done. We calculate the dosage of the tenecteplase for the given body weight, and the 1/5 of the dosage is given intra-arterial. And then you wait for about 5-10 minutes and you take a check shot. And that's what you see even at the end of 5 to 10 minutes. It's amazing to see but then the important message is just don't leave with the intracoronary 2 shots, or if you need the second bolus, you could give it depending on the bolus, but then the remaining should always be followed up intravenously, because you need that lytic milieu in the system. Otherwise, it is not really going to give the desired results. Over a period of time, he settled down, and it was encouraging to see the kind of opening that he had, and did it wonderfully well after that. And of course, there was a little bit of a thrombus which had gone distally. He was on heparin infusion, dual antiplatelets. He had a little bit of hemianopia which recovered. We also found that he had hyperhomocystinemia, discharged with an EF of 45, and right now is absolutely normal LV function with a fully recovered LV. So I think we had done, in fact, at least more than 150 cases of intracoronary. This was one of our earlier publications in intracoronary tenecteplase in STEMI with massive thrombus. This is a few years ago, actually. 45-year-old man, you can see the left main, the circ not getting opened up. Again, 1/5 of the dose bolus, you could see the results just in front of your eyes. What is very important is that if you've done a radial shot, you could see the result just like that. Sometimes when somebody comes with left main, you don't know what to do, and then you try to extract it, might come back to the ostium and then get embolized even into the systemic circulation. So again, tenecteplase at this point of time worked wonders. So that's the kind of encouragement. But then one must understand that you may not always get the entirely, because if there is a lesion, so you always need a check shot at the end of 4 hours. And that's what we do as per protocol. Only thing is, some of them are really prone for arrhythmias. And so when you take a check shot, sometimes there is a residual lesion, which you can easily do at that point of time without any problems. This patient needed a crossover stenting. And this was, again, another patient with an inferior wall myocardial infarction, huge thrombus, as you could see it. Again, after balloon dilatation, this is not opening, the post lysis, and that's what it is. And then after stenting, almost a clean vessel. The only message I want to give is, if you find huge thrombus on this thing, never try to wire this patient initially. If you're planning to give an intracoronary thrombus, the thrombolytic therapy, do it first. Take a shot about 5-10 minutes, see whether there's an encouraging this thing. You can, if the ECG resolution takes, most of these patients, the ECG resolution will happen within an hour's time. And then always a check shot at the end of 4 hours mandatory to see what the results are and to see whether they need a stenting further. So the conclusion is that most of them had a recanalized artery. Some of them had transient arrhythmias, but most of them, they do well. And that's what our experience has been with intracoronary. So despite all this, there were a lot of criticism when we sent this paper. Routine thrombus aspirin not recommended in the guidelines, considering large residual thrombus, particularly tortuosity, distal location, calcification. I just wanted to share another important thing where, in stent thrombosis, in fact, this is again got published. This is a guy, in fact, I was away on a vacation when this guy was admitted with an inferior wall. My colleague put in 3 stents there. And then he was on tirofiban infusion and all that. But in the middle of the night, again developed chest pain. What you see is the stent thrombosis. Despite multiple dilatations, he was stuck, called me up. And I said, there's nothing else that you can do but then give an intracoronary lytic therapy. And that was what you see after the first shot. And that is what you see the second shot. And that's what the final picture is. It's 4 years now. He's doing well. He's been to Shabarimala. His treadmill is negative. So I think the important message is that these are really adjunctive therapy, which works very well in the context of primary angioplasty. In fact, our confidence has grown further when we had, this was a patient recently, had 2 stents put in about a year ago, late stent thrombosis. This guy has also been under my care for a long time, had thrombus in the circumflex. And then with the balloon dilatation, this is what the picture was. It was not opening up. The thrombus was there. He was offered this intracoronary lytic therapy. You could see after the first shot, there was an improvement. But then these people need really, because there's a stent there, you need repetitive dilatation. And that was what the picture at the end of it. And the most gratifying experience was an elderly gentleman, again, had an angioplasty in 2002, LV dysfunction to the right. In my hospital, he infarcted, and that was what the angio was. So we opened up with a balloon. We found that huge thrombus entire way into the RCA. And so this gentleman again was given lytic therapy, and that is what is seen, and this patient is doing well. So I think our experience in stent thrombus also really been very good. This is definitely an adjunctive. But then the second patient subsequently came back to me with angina. He had actually a residual stenosis there, and I had to deploy one more stent. He's doing well right now. So I think the important thing is never get worried about the thrombus. This is again another interesting case. A young lady, otherwise normal, ectatic coronaries, came with an anterior wall MI. My colleague put in, tried to open it up, balloon dilated, and then found that there was a huge thrombus. And he found that there was a distal lesion, which was the reason for the occlusion. So he thought, why not just keep away from the ectatic segment, put in a stent there. He put in a stent there, opened up, post-dilated. But to his horror, and that was what the picture was, huge thrombus proximal to the stent, ectatic coronaries. What could you do? You could possibly not deploy anything there. And if you try to put in a thrombus extraction device, you will take the entire thing into the left main. So at this point of time, the wisdom prevailed. We lysed his patient intracoronary, and you could see the result very dramatic even at the end of this thrombus was. Again, we have always had a fear whether this would remain and whether the patient would have an event. But that is what it does after the intracoronary lytics. Now, this lady came to me. I make sure that I study all these patients. She had an anomalous right as well. So this patient was studied subsequently a year later, and that is what the coronaries look like. So I think there is definitely a role for intracoronary lytic therapy. And that's a message which I want to convey to the audience here when you are confronted with a huge thrombus in a primary PCS situation. So the intracoronary lytics can be in PAMI, huge thrombus, stent thrombosis, adjunctive in a primary angioplasty where, people are gaining more and more confidence, low dose intracoronary, along with your primary PCI. But then there are a lot of work going on in Australia and also in US. But maybe the years to come, you will find low dose tenecteplase as an adjunctive to primary angioplasty that might replace all your glycoprotein 2B3. It's too early days to talk about it. But I think it's the message is that there has been a reduced burden. But people have also been thinking at how best to, for example, the peripheral arterial disease, you have an acute critical limb ischemia. You have to go really deep into the thrombus and then instill your lytic therapy with a guide catheter. Whereas here, in a coronary, what could you do? People have thought about crossing the lesion and then putting delivering the thrombolytic so that both antegrade and retrograde there could be perfusion. These are all many schools of thought, but we find that just pushing it through the guide is effective. So where do we stand as far as intracoronary lytics in 2021? I think young patients with huge thrombus who present early and a majority of a plaque corrosion, you can actually obviate the need for a stenting. Patients with ectatic arteries, larger vessels, where I've shown clearly where mechanical thrombectomy may not work, this is very effective. At the ostium of LAD, when it's prolapsing to the left main, when you worry about a retrograde propagation of thrombus, again, there is possibly a role there. Acute stent thrombosis, patients with acute stent thrombosis, maybe perhaps the years to come as an adjunctive therapy in PAMI. So the TNK has an advantage of being a bolus push injection, and you can really, with an immediate visualization, you can see the results right in front of your eyes if you take a check shot 5 or 10 minutes later. And it can be delivered through anything, even with a guide, export, clearway, or whatever. However, you need really large-scale studies. The only thing that we have not been able to do is to conduct OCT on these patients after our lytic therapy. Thank you all for the kind attention.
Vinamad, sir?
Yeah.
Unmute, sir. I think great cases, sir. You have presented entire interventional cardiology, right from elective left vein, long stents, bifurcation, probably acute phase. But I'm very impressed by your passion for intracoronary lysis. Omkar, sir, we are collecting the data of intracoronary thrombolysis, tenecteplase especially. I think, sir, there's a lot of this thing. I think we should collect. What is the regular dose you are using in your place, sir?
Yeah, so what we do is we just look at the body weight, So if somebody is 60 milligram, what you recommended is 0.5 mg 30. 1/5 of this is given as intracoronary initially as a bolus. And then this thing is we always do a check shot at the end of 5 minutes, see what is happening. I mean, if it's a very early presentation, this thing, you see the results right in front of your eyes, and that encourages you. So if there's a huge thrombus, push another 1.1/5, which makes totally about 2/5 intracoronary. Remaining, I think the important message is it has to be given intravenous. It cannot just be intracoronary alone. It is not going to. And then, as far as possible, don't wire it if you're thinking there's a thrombus and there's no lesion beyond. Because sometimes wiring, if you dissect and lift a plaque somewhere, then this could be a place where you could have a further this thing. So I think, but
so if you come up with some sort of guidelines regarding the dosing, sir, because various people give different doses, sir. And there's no consensus on dosing. Probably smaller doses we give and check and then repeat. That is a general message. But I think we need to come up with some common dosing pattern.
Correct. Agree. I think we have done on more than 100 patients. So I think we are fairly very confident these days. In fact, all those people who have worked with me here, they were all pretty confident of doing it the way we do it. Only thing is heparin infusion is a must till then for another.
That is important because the short acting it could reocclude again.
Yes.
Dr. Jaya, this you give intracoronary TNK, and if it is a short story like 45 minutes or 1 hour, and then you are giving in the cath lab, most of the time you see the result in front of your eyes.
Correct.
And the clot will get dissolved and you would see a nice flowing artery. So in these cases also, do you need to, you are given 1/5 of the dose intracoronary. The remaining is a must, or you can skip it?
It's a must, sir. I think we have seen that, just giving intracoronary doesn't really work the way we expect, because earlier days, people used to use tirofiban, heparin along with this, but it doesn't work that way. I think the full lytic dosage is required. That's why, when you reperfuse, sometimes even with an intravenous, because the effect comes a little later. You need this thing in the system for at least a few hours. That's what we are seeing. And of course, when you take a patient for a PRAMI, our protocol is always just 5,000 before the guide is put in. Once the sheath is in, 5,000 heparin goes. So if you're given the full dose of tenecteplase also, it's good enough to continue the infusion of heparin immediately after your procedure. So this is as per the protocol for tenecteplase.
Full dose means what? The dose
let's assume that 30 milligrams is the total based on the body weight. Somebody has 60 kg weight. 30 is the body weight. So we give 6 milligram intracoronary. See at the end of, if there is a huge thrombus, I am pushing another 6 more, which is about 2/5 of the dosage. Remaining 3/5 is given IV before the patient is shifted out of the lab.
But the full dose must go in, that means.
Yes. Otherwise, you don't get the results.
Part coronary, part intravenous.
Yes, sir. The good thing about this is you see it right in front of you, so you believe that it is working. It's really documented as well.
No, that's fine. But why do you need intravenous after that?
Because you need the lytic dose in the system for a while. Otherwise, the whole thrombus will not go off. That's why, for example, somebody is 80 kg. Even let us think about an IV lytic therapy. If you use only 30 milligram in an 80 kg man, you may not get the required reperfusion in this patient. That's why we need the dose-adjusted dosage of 40 milligram in that patient. So the remaining has to go into the system.
You feel the usage of intracoronary lytics whenever you are struggling with a big thrombus load during angioplasty.
Correct, sir. I think, yes.
Yes.
Message is that, instead of
let's
using
say
all
somebody has received TNK on day 1 and the artery is open, but it still has a lot of thrombus burden. And you are doing angio on day 2 or day 3. And you would probably suck out the thrombus. And would you again give TNK intracoronary?
No, sir, I would not repeat it. After beyond 12 hours, I would not repeat it.
No, he has received it on day 1.
Yeah, he has already received it, and then I will not repeat it. And that point of time, because if the clot is remaining in place after a full dose of tenecteplase, whether it's IV or intracoronary, I'm skeptical about repeating. I never done that. So I always try to suck out
initially intravenous. The first presentation is an intravenous TNK. And say 2 days later, you're doing an angio with a view to do angioplasty, and you see a lot of thrombus. So it is artery is flowing. I mean, it's not a 100% clear-cut block, but you see blotches and artery is full of thrombus. So you would suck it, suck the thrombus, and in that case, the action of TNK is gone in first initial few hours. So what is the harm in repeating TNK?
Well, unlike streptokinase, there is no resistance or antibodies to that. So theoretically, it should work. But then, I've had only very few occasions where huge thrombus remaining. And most of these I have never tried using it again. I've always done either any mechanical or, removal at that point of time. But I'm also convinced, sir, somebody comes to you, for example, 24 hours post-MI. I think the corollary to the problem that I was talking about. We have been talking about people who come sufficiently early. There are a lot of patients who come after 24 hours and you do an angioplasty. The moment you wire the lesion, you find there's a huge thrombus. I'm not a big fan of using tenecteplase beyond 24 hours. So I have seen people using half dose of this plus glycoprotein 2B3A, which is not really recommended. But beyond 24 hours, that is one place where I am a little aggressive with the thrombectomy devices. Otherwise, today the use of thrombectomy devices in a primary, fortunately for us, we get most of our patients within 1, 2, or 3 or 8 hours. So the usage has drastically come down. Unless it's with the late presentation, I have no doubt that it will go for a mechanical thrombectomy.
So what would be your advice? Say, from my cath lab, somebody is about 100 miles and he is lysed by the local physician, and then he transfers the patient next morning to us. So let's say 24 hours are gone between lysis and patient is with me. And when I take a picture, it's a successful lysis because there is some forward flow, but still you see blotches of clots here and there. So in that case, I strongly feel I would definitely use GP blocker.
Yes. Beyond 24 hours, yes. Correct. By then, the effect of tenecteplase is gone off.
Effect is gone, correct. But is there a role of tenecteplase at that stage instead of GP blocker?
I am not too sure for the cost reasons also, because I never tried this once lysed, again rising with a intracoronary. I never tried. So honestly, I can't give you an answer about it, but I think it's appealing that you in this context, maybe just a low dose intracoronary alone perhaps might be sufficient, but I have no answer. I've been using mostly glycoprotein 2B3A or mechanical this thing in patients beyond 24 hours.
Suppose you are doing angioplasty on somebody who is lysed about 5 days back and he's with you today. He's lysed in a peripheral center and he's with you today on day 5. And then you find a lot of thrombus. What do you suggest we go about it? One is thrombus aspiration. And still you have a lot of thrombus in that artery. What are your suggestions?
Yeah. So if I find a huge thrombus, let's say, look at the right, for example, let's hypothesize somebody has got a right occlusion or a LED occlusion right from the proximal part, and then if by a moment a wire and balloon, I find thrombus. What I would do at that point of time, anyway, the patient is stable, not in continuing pain, 5 hours, 5 days beyond. So I would keep this patient on a 24 hours of a glycoprotein 2B3A, and then bring him back to the cath lab and redo the procedure later.
No, you would not. I mean, somebody who is lysed earlier.
Yes, 5 days. You said 5 days.
Oh,
Obviously,
okay.
5 days means he's settled well. So clinically settled well. And then, it's either a total occlusion or maybe if there is an antegrade flow, well, I would finish off the angioplasty in the same sitting. Otherwise, if there is no antegrade flow and then my balloon has just opened up, but I find huge thrombus from this end to that end, I would keep this patient on glycoprotein 2B3 at least for 12 to 24 hours and then take a check shot and see what it is. And then would lyse it.
Intralesional
Yes.
GP blocker?
Yes, intracoronary, yes.
No, not through the guide catheter. But you.
No, we always give a bolus, sir, that way, through the guide catheter, yes.
No.
Guide catheter, you would give a bolus and then follow with an intravenous for 12 hours in the CCU.
You're talking of what? You're talking of GP blocker or?
Glycoprotein 2B, yes. Tirofiban or tirofiban is the most commonly used one these days. Yes.
But I thought even GP blockers, when you have blotchy thrombus all along the vessel, if you give intracoronary GP blocker, I mean, you have different kind of catheters available, which would go there and they would do a continuous lysis along the whole length.
You mean clearway and sort of, yes.
Yes, I mean, we have had many cases where lysed on day 1, then with you in the cath lab on day 3 or day 4, and say blotchy clots along the entire RCA. Patient is stable, but you know where to stent, obviously, because the whole vessel is sort of looking patchy, and you need to have a separation, which is a thrombus and which is a lesion. And for that, I would do the way you said, that bring them back a day later after giving some kind of anti-clot therapy. This anti-clot therapy, according to you, should be a GP blocker. And I entirely agree that it should be a GP blocker. However, I would put the GP blockers down the artery and not just the intravenous route. I mean, you have a guide catheter through which you put a perfusion catheter, and through that you continuously irrigate entire vessel, especially RC. This also holds true for some of the vein graft cases we have done. Like you see some flow, you feel encouraged to do something, but vein graft is a completely difficult ball game, and that's why we instead of giving through the guide catheter, we irrigate right in the lesion. So intralesional, either lytics or GP blockers, they work much better than giving it through intravenous.
I agree, sir. I think there is a role for that.
Dr. Onkar, any questions in the chat box or anything?
No, sir, no.
Oh.
So just wanted to share, Dr. Srinivas sir had to leave. He had some important work, so he texted me in the box. He's not presently in the meeting.
Yeah, I think we are almost coming to the end of the meeting.
Yes.
And, So we had three very important talks. Each had a different meaning, and clot remains a big issue. Many times it happens so easily that you put a wire, the flow starts, you give some GP blocker, or if early enough, you give Alexium intracoronary, and the vessel starts looking beautiful except for the local site, which you put a stent and dilate. These local sites, I would probably feel that I would put a slightly oversized stent and not use high pressure. By using oversized stent, you probably can get away deploying the stent at a relatively low pressure, something like 6 or 8. And if at all you want, you can bring them back a couple of days later when there is no thrombus, and then stretch the stent to the fullest. But generally, it is never required, and most of the time, whatever you do on day one is good. But I'm clearly more for putting a bigger diameter stents. Also, one must remember that the vessel is sort of in some degree of spasm when this acute event is happening. So the vessel diameter seen is probably slightly lower diameter than what the vessel is. So in a thrombotic or an acute situation, to avoid high pressures, I would rather prefer an oversized stent at a slightly lesser pressure, so that A, you don't distally embolize the clot from the local side, and B, the vessel is probably shrunken today during the acute phase, and the stent will match the vessel diameter a few days later when the stent is fully to its diameter. So these are some of the thoughts I would probably like to share. The other issue is sometimes the course of the vessel may not be the way we normally expect it to be. And when you are wiring through a totally occluding thrombus, if the wire takes a different kind of course, you are concerned because you feel whether the wire is in the side branch or wire is not following it's the vessel course. So in that case, a low pressure balloon inflation of a small diameter balloon and then a diluted contrast would outline the distal vessel. So this track of the distal vessel is very important. And this is especially true when the artery, especially the right, is originating as an anomalous artery somewhere close to the left artery. I think these are some of the comments, but I think today's presentations were fabulous. I really loved them. And Dr. Onkar, you would agree that we are growing in our size because of the specialties who come on the stage on this forum, and we continue to grow. Thank you all, and appreciate your presence.
Thank you very much, sir.
Thank you very much.
Thank you, sir.
Dr. Hiremat sir, thank you very much. Dr. Sahu sir, thank you very much. I thanks Dr. P.B. Jaigo Palser for presenting an interesting case presentation. I also thank Dr. Vijayan sir and Dr. A. Srinivas Kumar sir being a part of this program. So we'll stop here, and next year we will meet again with three more interesting cases. I wish a happy time ahead and a happy new year. So we'll be catching up into next year with next set of event. With this, let's stop here, and I wish good night and great time ahead.
Good. Merry Christmas.
And a Merry Christmas as well, sir. Merry Christmas to everyone as well.
Yeah, Merry Christmas and a Happy New Year.
Happy New Year.
To
Thank
you
you.
too, sir.
Thank you.
Good night. Good night, sir.
Good night. Good night.